Hello everyone, I'm Huilin Zhao, a radiologist from Shanghai Renji Hospital. It's my honor to be invited to give an educational talk, 3D Carotid MR visual imaging, technical adaptions and clinical application. I have no potential conflicts of interest. What clinical questions need us to answer by using 3D Carotid MR visual imaging? Here are the three groups of people who come to hospital. A is asymptomatic subjects who want to do some carotid vascular physical examination. B is asymptomatic subjects who have stroke risk factors or have diagnosed as carotid stenotic lesions, need to do some additional exams to get information about the lesion severity. C is symptomatic subjects who have stroke attack to figure out the etiology. For these asymptomatic subjects, we can truly use 3D MR visual imaging to screen the carotid artery. Looking behind the lumen, the visual is clearly shown and the radiologist can tell the normal or abnormal. Meanwhile, we can differentiate the carotid atherosclerosis from the dissection, vasculitis, or other disease by reviewing the morphology of the vessel and the wall lesions, including location and the distribution, stenosis grade or surface like ulcers, plaque components. For these subjects with advanced carotid lesions or who are involved in some research projects, quantitative analysis, including visual remodeling, plaque burden or size, plaque component proportion, and information are asked to collect. A clinical decision can be made combined all these carotid image data and other stroke-related clinical profiles. So here comes the first question. What is the optimal 3D carotid MR visual protocol for carotid disease diagnosis? Here is the latest expert consensus from ASNA visual imaging study group and with dozens of carotid visual sequences and hundreds of references. In the last 20 years, there has been a paradigm shift in the imaging of the atherosclerotic carotid artery from the assessment of the degree of the lumen stenosis to characterization of the plaque. In short, we have to identify these carotid essential features including lumen surface condition, plaque burden and distribution, and the presence of high-risk features, intraplaque hemorrhage and lip-rich necrocore. Example protocols are presented based on the considerations for 2D and 3D imaging and the use of gadolinium contrast. The protocol may include any combination of the sequence that meets the minimal requirements set above. But in our clinical settings, the above protocol are still time-consuming, and does every subject need to scan all these sequences if he has normal or early carotid lesions? So what we expect is a fast, like CT, large coverage of the whole extracranial carotid arteries and multi-contrast in 1 or 3 protocols. Recently, some novel and promising 3D fast sequences have emerged. Let's do some literature review by comparing them with the conventional 2D or 3D consequences. First, let's ask who's faster for carotid scanning. This study found that compressed sensing T1 space allowed better visualization scores and sharpness compared with conventional T1 space in evaluating carotid plaques and visuals, with 2.5-fold accelerated scan time with comparable image quality. Another study group found that compressed sensing visual imaging facilitates comprehensive visualization of intracranial and carotid visuals with high isotropic resolution with a single 5-minute scan. Amazing. Second, who's all round? A streamlined imaging protocol that is able to identify multiple imaging targets in one or two imaging sequences. Match sequence developed by Lee's group acquires spatially co-registered multi-contrast image sets in a single scan for characterization of carotid plaque composition and provides comprehensive information about the major plaque components. SNAP sequence developed by Chen Yuan's group detects more interplaque hemorrhage and show excellent agreement with conventional empiric sequence and multi-contrast imaging in identification of both calcification and ulceration, suggesting that SNAP imaging may be a time-efficient alternative tool in identification of carotid plaque surface and other features. Third, who's better for carotid plaque diagnosis about accuracy and reliability? As reference, 2D conventional multi-contrast MRI, 3D multi-contrast visual wall imaging provides comparable performance in morphology measurements and identification of carotid plaque components with good inter-reader reproducibility. And who's powerful for functional imaging? Yi Bingxie and his colleagues developed a 3D diffusion-weighted imaging. It has higher spatial resolution and better image quality than single-shot 2D DWI. 3D DWI can potentially detect lip-rich necrocore without the use of contrast agents. And Wei Yu's group found multitasking DCE is a promising approach for quantitatively assessing the vascularity properties of the carotid vessel wall. And this study from Cambridge demonstrates that the feasibility of using a single sequence to acquire both high-resolution 4DCE MRI and DCE MRI to evaluate both plaque surface morphology and function. Huijin's group proposed a large coverage black bright blood interleaved imaging sequence for 3D DCE MRI of the vessel wall. Oh, so many novel sequences and techniques. How can we use simple way to do the analysis? Yuan's group developed a 3D high spatial resolution time-efficient sequence named GoSNAP for use in quantitative vessel wall T1 mapping. They also developed a machine learning-based algorithm to segment plaque components on SNAP images. These efforts might be promising for atherosclerotic plaque components assessment. And what we need for 3D carotid MR vessel wall imaging? I think it's not hero's hard fight. We all radiologists prefer some effective imaging processing tools for efficient quantitative identification of imaging targets as easy as snap our fingers. The third question, is 3D carotid MR vessel wall imaging ready for screening? Here are two papers compared with TOF MRI, contrast enhanced MRI, and using DSA as reference. 3D fast black blood techniques enable accurate diagnosis and the lumen feature assessment of carotid disease, suggesting that this imaging modality may be useful for routine imaging workups and provide comprehensive information for both the vessel wall and lumen. As a systematic disease, atherosclerosis commonly affects intracranial and extracranial carotid arteries simultaneously. Sheehan's group found coexisting intracranial and extracranial carotid artery plaques are prevalent in symptomatic patients. Meanwhile, a substantial number of high-risk plaques can be found in asymptomatic elderly subjects. A Canada's group evaluated the cost-effectiveness of MR imaging as a first-line modality to assess carotid disease and guide management for high-risk patients with less than 50% stenosis. They concluded that compared with the carotid duplex ultrasound, using MR imaging as a first-line method to detect the presence of intraplaque hemorrhage provides clinical useful and cost-effective information that allows for enhanced risk evaluation and primary stroke prevention. How about in China? Carotid artery exam and brain CT or MRI is involved in routine physical exams in most big hospitals. A 3D carotid MR with wall exam costs about 30 hamburgers, while a carotid ultrasound costs 5 hamburgers. Is it worth to use 3D MR with wall image instead of ultrasound or set up a neurovascular one-stop inspection? Let's wait and see. Thanks to my colleagues and collaborators. Thanks for your attention.